Well, thank you all for joining us at CTIC's most recent event on COVID vaccines for developing countries. We are delighted to be the host of this fantastic panel on what is an oft overlooked dimension to one of the greatest, probably the greatest public health crisis, certainly of our lifetimes, but also beyond just a public health crisis, just a general global challenge. And we are delighted to be part of what I think is shaping up to be a very important discussion. This is not only a cutting edge issue, but this kind of event epitomizes really CTIC's vision of the kind of community we're trying to foster here, which is a commitment to interest in the overlap between legal issues and technological issues in a way that brings together a robust community of faculty and students. And this is, you often see different programs which are faculty driven or student driven, and we really pride ourselves here at Penn Law as having this wonderful collaboration. And this panel is sort of a prime example of that. Anthony Tran, who is a student, organized it, conceived of the event, organized it, and brought it to us, and we are delighted to be the beneficiaries of his vision, his drive, and his commitment to the issues that we're going to discuss today. And I will get the pleasure of handing off to him in just one moment. But it's also another wonderful opportunity. Go ahead, Anthony, come on in. It's to welcome three people who, as a group of speakers, who I think are fantastic. I'm delighted to have the chance to be with here. Distinguished alumni Anthony Brown, who will be joining us shortly, and two wonderful friends of mine, my Penn colleague Harvey Rubin, and Harvard Law School professor and longtime associate Ruth Okadiji. And without further ado, I hand it over to Anthony.
Hello, everyone. Thank you for coming today. I'd like to thank the panelists here for being here. Dr. Harvey Rubin is a professor of medicine at the University of Pennsylvania and a professor of computer and information sciences here at the School of Engineering and Applied Sciences. Dr. Rubin had the idea of leveraging the pervasiveness of cell towers to power vaccine refrigerators in remote areas in developing countries. And from that, Energize the Chain was born and has launched programs in Zimbabwe, Myanmar, Bangladesh, Ghana, and is currently expanding into other countries, protecting underserved populations from preventable diseases. Energize the Chain is working hard to help countries strengthen and extend their cold chain infrastructure to now include distribution of any of the new COVID-19 vaccines. And then Anthony Brown is a Penn alum. He's class of 2004 at the law school. He is currently senior legal counsel with Gavi. He has helped with the establishment and financing of various initiatives to incentivize vaccine manufacturers and fund immunization programs in developing countries. He has also advised on and negotiated multiple private partnership agreements, such as Gavi's 2016 advanced purchase commitment for an Ebola vaccine. Gavi is an international organization aiming to foster public-private partnerships and promote equal access to vaccines around the globe. And then lastly, Professor Ruth L. Okadiji is a professor of law at Harvard Law School and a renowned scholar in international intellectual property law and the role of intellectual property in social and economic development. She was appointed by United Nations Secretary General Ban Ki-moon to the 2015 to 2016 high-level panel on access to medicines, and her scholarship has influenced government policies in numerous developing economies around the world and helped shape national strategies for implementing the WTO TRIPS agreement, which established minimum standards for regulating intellectual property. She works closely with several United Nations agencies, research centers, and international organizations on international intellectual property policy, including access to essential medicines and issues related to indigenous innovation systems. To begin, I would like to start off with the main idea of this panel about the biggest challenges to securing COVID vaccines in developing countries. I'd like to begin with Dr. Harvey Rubin, and then Anthony Brown, and then Professor Okadiji on what they see as their biggest challenge and what they see as the most effective solution to try to, I guess, address that big challenge.
And Harvey, before you begin, I realized I forgot to do a couple administrative duties. I should note to the audience, this is being recorded. And so as a matter of notice, for people who want continuing legal education credit, 2 passwords will appear during the course of the presentation. Closed captioning is available, and the panel will take questions at the end through the Q&A function that is supported, that you will see at the bottom of your screen. And with that, I will get out of my way now that I finally discharged all of my duties and hand things over to Harvey.
Great, thank you. I think, let me make sure that so you can hear me. I'm going to share the screen now for a few slides, and I want to thank you for inviting me. I think it's an honor to be here and be an honor to share the Zoom meeting or whatever it is with my colleagues. So I'm going to share the screen now, and let's see if we can do that. There we go. Okay. So great. And I'll go on. Let me get rid of that. Okay, so I'm going to tell you a little bit about our project called Energize the Chain, which, as Anthony said, really grew up in order to solve the problem of extending, enhancing the vaccine cold chain. And this started well before COVID. You can see here pictures of what the idea is. The idea is to make public-private partnerships between the private sector, where there's tons of energy in the developing world, believe it or not, and the public sector ministries of health. So where is the energy? Every vaccine has to be kept cold, which means you need a refrigerator, which means you need power for the refrigerator. It turns out that there's a ton of energy in the developing world, just about everywhere you go, because everywhere you go, there are cell towers. And cell towers, you can see here, are very close by villages. So we had that idea to do this public-private partnership. Let's see, how do I go to the next slide? Okay, so what is the cold chain? Why is this important? It's important because millions and millions of children die because they don't get a vaccine, because the vaccine basically goes bad if it becomes too warm or if it freezes and thaws. Not only do they die, kids die, but they also have preventable diseases that they get. So no kid should get measles these days. No kid should get polio. And now, of course, when we're talking about COVID, those numbers are just enormously increased. This is the cold chain. It starts at the manufacturer. Most normal vaccines, and I'll change this notion when we talk about COVID, have to be kept between 2 and 8 degrees Celsius, so about 35 to 46 degrees Fahrenheit. Right from the manufacturer all the way down to the airport, to the primary vaccine store, to the health center, to post, and finally to the child and the mother. And believe it or not, this is how vaccines are delivered in many parts of the world. And this is how vaccines are actually stored in many parts of the world. Clearly, not an adequate cold chain. So this is not just our observation. This has been observed by everybody from the World Health Organization to Gavi, to UNICEF, to USAID. This is how vaccines are many times stored in areas in low and middle income countries. The ability to maintain an adequate cold chain is broken down to, is the equipment there? Is it performing well? Do people know how to use it? Do they know how to replace it and procure new pieces of equipment? And the answer to many of those questions, unfortunately, is no, 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 and no. So what can we do if we can improve the cold chain? This is a paper that came out of the World Health Organization. Clearly, it reduces morbidity and mortality. It can easily and primarily enhance and expand the delivery of vaccines. It expands distributions. It reduces waste. If the vaccine heats up, they have to be thrown away. And if people stay healthy, they don't really put the strain on the healthcare system. So the idea of vaccinating kids has been around for a long time. The idea of vaccinating children with adequate security has been one of the problems in public health for decades. And now COVID makes this even much more a difficult problem to solve. Why? These are the vaccines that are out there now. And you can see over here on the right-hand side, the AstraZeneca vaccine, that needs to be kept at the usual temperatures, 2 to 8, 2 doses. Moderna and Pfizer, I got the Pfizer vaccine, that has to be kept very, what we call ultra cold. So minus 80 degrees, that requires a completely different refrigeration system. The Russian one also needs to be kept quite cold in one form. at about minus 20 degrees Celsius. Many of the others, and the good news is that the other ones, including the Johnson & Johnson, is okay to be kept at 2 to 8, like the measles, mumps, rubella vaccine. But you can see the actual infrastructure that's required in low and middle income countries to sustain this kind of logistics is close to impossible, very, very difficult. So our approach is to do these public-private partnerships. As Anthony mentioned, we do work in some very difficult countries. We work in Zimbabwe, we're working in Myanmar, we're in Ghana, we're in Bangladesh. You can imagine the difficulty we have with working in those countries. There's a number of security issues. There are a number of logistic issues. There are a lot of legal issues that come up. You know, who has the right to sign an MOU? If you're in Myanmar and there's a military takeover, do the MOUs still carry weight? We had the same problem in Zimbabwe. We had an MOU with the Ministry of Health. There was a military takeover. What are the legal recourses with our original MOU? So I'm thrilled to talk to the lawyers in the crowd, because these are real issues. We're funded by private foundations, we're funded by Gavi, we're funded by individuals. And so we do have a responsibility to our donors. And if we are shut down for whatever reason, and usually it's because of the political situation, what is our responsibility and our legal obligation? It turns out that the public sector is sometimes the more difficult sector to deal with because of these political and social and economic instabilities. The private sector in these countries really do see a benefit, whether or not they're funding us through their corporate social responsibility. And in Zimbabwe, we have a great benefactor in the cell tower company called Econet. In Ghana, another great benefactor in the private sector called American Tower, which is a major tower company. In Bangladesh, we have a partnership with other local and global power companies. So the private sector sees a great benefit, so does the public sector, but there are instabilities in both. And the legal issues that are raised by writing these MOUs and actually working in a country where our own people are at risk can be very problematic. So I sent 2 students to Myanmar 2 years ago. I was there, it was stable, it was safe. I would be very hesitant now to send students to Myanmar, although we do have people on the ground and they're functioning sometimes at their own risk to carry out the mission of getting vaccines to everybody. Trying to reach kids between the ages of 1 and 5 is difficult. Trying to reach every soul in the globe is exponentially more difficult. And as the saying goes, COVID anywhere is COVID everywhere, is really quite true, especially with the emergence of these variants, because we may stamp it out here, but if there are variants arising elsewhere, we've got to be there and we've got to be there quickly. I have a whole little section on the role that Gavi plays, but I think Mr. Brown will probably be talking more about that. Just briefly, for another minute or two, Gavi has started this program where all the countries that we work in, Gavi eligible countries, are now able to put in an application for Gavi supported vaccine delivery for COVID. It's a complicated system. They are meeting a tremendous need. I'll share these slides with you. Basically, they have what's called AMCs, Advanced Market Commitments. They will guarantee some portion of funding for these new COVID vaccines. Of course, many of the countries we work in don't really want the Pfizer or Moderna because that puts a tremendous demand on their infrastructure because of the cold requirements. So the more stable the vaccine, the better. We can come, in case Mr. Brown doesn't come on board, we can come back over the COVAX program that's being run by Gavi. So I think my 10 minutes are basically up. And the key thing is getting the equipment, getting it stocked, and keeping tracking and tracing and following the kids and the adults who do get vaccinated. So I will end there and turn it back over to Anthony. And again, always welcome the questions. Thank you.
Thank you so much for your presentation, Dr. Rubin. This project sounds incredible. Professor Okadiji, if you guys need a CLE credit, there is a poll for the code word. And yeah, if
we had one request for it to be given orally. The word is vaccine.
And Professor Okadiji, if you could share more about Africa and access to COVID-19 vaccines. Thank you.
Thank you so much for asking me to join in this important conversation this afternoon. As we all know, and thanks to Dr. Rubin, I think really for laying the groundwork so clearly, the challenges, and in particular because that work is so much focused on the most vulnerable population, children. I think it's important for us to keep in mind that the problem with access to COVID-19 vaccines, you could just say access to medicines and swap out any pandemic to come, any past pandemic, existing chronic health situations, and the challenges are quite distinct. One set of challenges that I want to emphasize this afternoon is both the social challenges, the infrastructure challenges, and of course, challenges related to intellectual property. The World Health Organization has listed the Pfizer and 2 AstraZeneca Oxford vaccines on its emergency use listing. And this is, of course, as many of you know, a prerequisite for the vaccines to be added to the COVAX initiative directed at equitable global access, as Dr. Rubin has discussed. Beyond the vaccines by Pfizer, Moderna, and AstraZeneca, there are also the vaccines by Russia, China, and India. Now, despite what appears to be quite a number of vaccines available, Africa is far behind other countries in terms of vaccine, other continents, in terms of vaccines administered. At the moment, we have about 0.2 vaccines per 100 people. That's right, 0.2 per every 100 people in the African continent, as compared to 10.6 in North America, 6.3 roughly in Europe, 2.3 in South America, and 1.6 in Asia. Only 2 countries in sub-Saharan Africa, the Seychelles and Mauritius, have started vaccinating a majority of their frontline workers. Many experts say that large parts of Africa won't be vaccinated until 2023 or even 2024. That assumes that the variant situation doesn't actually even overtake what currently exists. There have also been further concerns of vaccine hoarding by industrialized countries such as Canada, which has pre-ordered enough vaccines to cover 500% of its 500% of its population. And of course, this sort of behavior will only exacerbate the risks that many Africans face. And as Dr. Rubin has noted, it has become clear that this is just an untenable situation. The longer that vaccine hoarding or lack of access lasts, the more socialized the access problem becomes in Africa. And this, to me, this informal but very substantial social and psychological resistance to addressing the lack of vaccines is a really significant impediment to which not enough people are paying attention. This is a picture in Kibera, in the slums of Kenya. You see beautiful mural art of the coronavirus being chased down by frontline workers. Children are skipping by happily by this mural, not paying it too much attention, but it is symptomatic of what I fear is occurring, which I describe often in my speaking engagements as the shudder and shrug effect. That is, there is a shuddering and a sense of challenge of what COVID-19 is wreaking on the continent. But in reality, at the end of the day, the longer it takes to get access and the more people feel the sting of death by starvation because of food insecurity, or the concern that they're not able to generate income, the more it becomes normalized. And this is, I think, quite a significant challenge on the continent. You all know the story that, that Africa has not suffered as many deaths as was feared at the onset of the pandemic. Here you see, as of January, and frankly going even into February, you see where we were seeing the peaks, but really Africa has not been the disaster that many public health experts feared. The death rates are still among the lowest in the world. Some countries are reporting as little as 1 death, and some countries even suggest no infections. Even when you account for underreporting, the death rate in Africa appears quite low. There are hotspots, in the South African variant, which is at the root of the 3rd wave in the southern region, is really being targeted as the root of that 3rd wave, but still the shudder and shrug effect continues on the continent. I think, though, that this is contradictory. This is a picture just from about 4 weeks ago, fresh plots at a Johannesburg cemetery, which shows you just the devastating effect that these deaths have, particularly when you think that when the virus attacks in a particular community, particularly a small community, it's compounded not so much necessarily by comorbidity, but just the lack of basic sanitation, the lack of infrastructure, and of course, poverty and food insecurity. So how do we think about access to the vaccine, and what are the considerations? A month ago, the World Health Organization regional director for Africa, Dr. Moeti, said it's deeply unjust, and I quote, "deeply unjust that the most vulnerable Africans are forced to wait for vaccines while lower risk groups in rich countries are made safe." And the CDC director in Africa has warned, or the African CDC director has warned, that it will be extremely terrible to see rich countries receiving vaccines while African countries are left behind. It's being described as a catastrophic moral failure and targeting vaccine hoarding in particular. But of course, we all know that there are other challenges. If you look at the vaccine doses secured by countries globally, it just shows you what money can buy. And in the poorest countries, that means very little. And so what Africa has done, as it's watched other regions begin the rollout, is that, of course, COVAX has just announced that it will ship 90 million COVID-19 vaccines in February, and it has started, actually, the shipments have begun, but countries have to submit national deployment and vaccination plans. The challenge is that for many countries in sub-Saharan Africa, the capacity to even draw up these plans is severely lacking. And I think whenever there is an effort to distribute public goods, this is the kind of challenge that many in the international organizations and nonprofits don't really appreciate, as Dr. Rubin mentioned, the significant public failure that exists at the level of many of these countries. Even if you have the COVAX effort, which is laudable, one of the challenges is that eligible countries are capped First of all, countries have to qualify. So if you don't, in fact, submit a plan, you don't get it, which means citizens are left at the mercies of their countries. But the other challenge, of course, is that even if your country submits a plan, eligible countries are capped to receive doses that cover only 20% of the population, which is far below the required 70 to 90% that is needed to achieve herd immunity. In a recent paper, my colleague Terry Fisher and another colleague, Padma Gail-Sampath, have really focused on this combined effect of vaccine hoarding, vaccine nationalism, challenges on the ground to distribution, particularly when it comes from outside sources, and the realization that even on its best day, vaccine distribution and inoculation in the African continent is going to be a problem. With 1.3 billion people on the continent, Africa's experience with the HIV/AIDS epidemic, in which more than 12 million Africans died, we are of course, I think as a global community, not wanting to see that outcome again. The African Union has secured an additional 670 million doses, which it plans to distribute. And the idea is that by the end of 2022, at the earliest, given the combined efforts of COVAX and the African Union, that we will have achieved at least 60% of vaccination. That's unlikely in the real world to be the case. Why? Because there is still a lack of vast purchasing power. There are complications with coordinating supply chains, and there are last mile distribution problems in resource poor settings. And so the paper really has three main proposals, but then also two issues that we think are important. First, clearing the legal space. This is a problem when you think about the intellectual property situation on the ground. Production triangles, a second suggestion, that is combining local production with partnerships, joint ventures, and then of course, technology transfer, getting the knowledge out there to deal with side effects and to deal with education. There is, of course, then the problem of quality control. We already have substandard vaccines in circulation in Africa, and the possibility of leveraging regional organizations like ECOWAS, et cetera, to deal with the purchase demand in advance. I thought it would be useful for you to see the current landscape of patents on COVID-19 health technologies. And so the combination of the need to clear the legal landscape really pushes on the lever of emphasizing local production, which has now become clear is the next big step for Africa when it comes to access to essential medicines, but also access in general to COVID-19 vaccines. COVAX, as we know, acts as an insurance policy in which higher income nations pool their purchasing power to spur investment in local manufacturing and to subsidize these medicines in the developing world. In turn, the developed world is insured by increasing its chance of receiving enough doses. But as I've said, we already know that this is insufficient. And so if you look at the way access is defined by those who hold the intellectual property rights, Gilead plans to donate. Co-Diagnostics says that its pricing is going to be compassionate. Regeneron, as a treatment regime, is offering 300,000 patient doses at no cost. Moderna has pledged not to enforce its patents during the pandemics. And then, of course, Pfizer has the agreement with COVAX. I think what you're seeing by this slide alone, and I'll wrap up here, is that there is a severe there's a complex combination of things that hinder access to vaccines in Africa. With nearly 2 billion people globally without access to essential medicines, many have now begun to see local production as the next important big step. Local production plus access to the patented technologies that often are not available in the global South. Beyond the COVAX procurement mechanism, UNCTAD and the WHO have teamed up to boost local production in developing countries. This effort would protect African governments when the next pandemic hits, but of course it relies upon coordination with foreign governments, trade policies, and an intergovernmental approach to thinking about how to limit intellectual property barriers by creating, for example, a COVID-19 technology access pool. This is an initiative which is intended to reduce the costs of knowledge sharing and leverages collective data and research in the academy. So if you look at the patent filing activity, you can see already the ramping up of patent filing activities on COVID-19 technologies. It tells us that given what we do not know, we don't know how long the current vaccines last. We don't know what these variants are going to do. And so the more we have patent filings clustering on the landscape, the more clearing the legal space for local production is going to be problematic. It will require, I believe, both intergovernmental and inter-organizational collaboration. So lots of miles to go to improve access to COVID-19 vaccines, both those that are donated and those that will be locally produced. We have to deal with disinformation, misinformation, storage capacity, which is what Dr. Rubin's group has really been working so hard on, infrastructure, and very importantly, the history. Right, this history of repeated failures to attend to the externalities imposed by the lack of access in the first place and the need to wait for so long. I think it's important to note that local production is already beginning to be part of the conversation very seriously. And we are looking in particular at the possibility of what these regional organizations can do by making advanced commitments to procure medicines generated by local manufacturers. So in the longer term, the paper that we have just written really looks at internships as a form of technology transfer through these triangle production mechanisms, collaborations across institutions, and of course, addressing the EU, the IP issues, not just in Africa, but in much of the global South. The global community must work together to get Africa vaccinated much faster than the roughly 3 to 5 year time frame that is being estimated now. If the world's poorest communities go unvaccinated, I think it's clear that we all are at risk that the price will be shared by all of us. Thank you so much.
This is Harvey. Can I jump in for 1 second? Professor Okadichi, that was brilliant, absolutely brilliant. I wish I could have said, I hope you'll share the paper with us.
Yes.
I want to add one other some complication, and one would be this whole concept of something called pharmacovigilance. We're giving out millions and millions of doses, but when we start talking about inoculating billions of people with vastly different genetic backgrounds, vastly different environmental exposures, vastly different pre-existing conditions and exposure to infection rates. I think what we really have to pay attention to as well is what we call pharmacovigilance. And that infrastructure is incredibly, only at the earliest stages. I know after I got my vaccine at Penn, I got these emails for about a week or 2 or 3 afterwards asking me if I had any fevers and all that. It supposedly goes to the CDC. There is no pharmacovigilance that to speak of in the countries that we're concerned about. And especially if you start talking, whose responsibility is pharmacovigilance actually? Is it the production people, the manufacturers? Is it the public health sector? If we start talking about local production and local facilities, do they have the infrastructure to put in place a pharmacovigilant program? We'll learn a lot. So far, luckily, the vaccines look very, very safe, and thankfully that's the case. But we really have to start thinking about follow-up in all these people that we're starting to vaccinate, because when you start doing billions of people, things will show up, and we need to learn about that.
Absolutely. And I think this is one of the reasons why we emphasize really clearing the legal and regulatory space on the ground, because there's a lot of data that intellectual property owners don't have to disclose. And some of that data may be necessary to do the pharmacovigilance that will help us understand how these vaccines are really working in a continent, particularly like Africa, but I think Asia as well, with vastly different genetic background, vastly different social-cultural conditions. So that's a huge issue because we think of the intellectual property system as a national system. So it is no surprise that vaccine nationalism has kind of tied into this very national territorial view of patented health technologies. But global health, right, is a global public good. And the reality is that if there are huge swaths of people who never achieve herd immunity, or for which the consequences of the vaccine suggest something different, we are all still at risk as a result of this. And I just think also the moral question of, is this really the way we want to deal with epidemics, right? To have rich countries always having it first, and to have no plan, no system, no reform at the intellectual property level in particular to deal with public health crises. What we currently have, the Doha Declaration, the Paragraph 6 solution, all of the things that emerged in the wake of the HIV pandemic simply are inadequate. And we have seen that proven time and time again.
Right.
Yeah, regarding seeing that time and time again, I was wondering if we had learned anything from 2009 when rich countries had bought up the global supply of the H1N1 vaccine. Was there nothing put in place to, I guess, have some chance of reform after that?
Ruth, I'll let you answer that question.
Well, I think the obvious answer is no. And,
Yeah.
and this is something that lawyers have to think about, and frankly, government policymakers as well. It is a complicated system that we have created. We have a patent system that's fundamentally national and territorial. We have a drug approval system that's fundamentally national and territorial. We then have fairly loose scaffolding provided by Gavi and COVAX and UN agencies, et cetera. But those regulatory schemes on a global basis do not disclose data that would strengthen the capacity of global South health institutions to begin to learn how to both do the pharmacovigilance, perhaps encourage local production, or engage in interactions with the health providers or the vaccine or the medicines providers to really understand the data in a way that would both generate competition but also facilitate global and national welfare. And those tensions have not been worked out. We this is, I tell, sort of like to say that this is not just case by case. We are adopting an epidemic by epidemic approach, which strikes me as precisely the thing not to do. Once, and I think Ebola, we saw such a rapid end to Ebola because of the high death rate and quick death rate of that epidemic. And there are still outbursts of Ebola happening, but it is the same sort of fundamental structural problem, which is the rich will get it and the poor don't. And we see the best action when rich countries and rich people, and I mean also rich people in the global South, are affected by the same pandemic. We see radically different responses than if it's just a poor person's disease. And we're seeing that even in the US with how hard it is to get to rural poor communities, even with a vaccine, right? So this is something we have got to take much more seriously, and our moral obligations have got to become much more intense, and we've got to get the law to respond to the intensity of the moral crisis that we're seeing in public health.
Let me add to that. It's so beautifully said. There are two other structural parts that have failed. One is the basic research, the funding for basic research. Infectious disease, and maybe I'm feathering my own nest because my world is funded by national grants. The actual funding for this kind of work, even trying to get a general platform for vaccine development, far, far lags many other funding opportunities. So the world has to confront the idea, and this is unfortunately exactly what happens. The fact that the funding for this kind of research has lagged many other kinds of funding, and that's just inexcusable. And this shows what could happen. Secondly, that's on a local scale, what happens in my lab down the hall. But on a global scale, there's no global governance that really addresses this issue. It's all very sovereign based. So you see, if the UK allows a certain emergency use application, there's another whole application that has to go on in the United States, and that lags behind. So the same thing is true around the world. And if you're doing clinical trials in one country with a group of patients, that may not be accepted in another country. And there's good reason for that. There are different genetics, different populations, different strains circulating at the same time. So, but there is no global governance for vaccine acceptance or medicines acceptance. And I think if people ask me this all the time, how would I change things? I would obviously do more funding for basic research, but I would spend a lot of time worrying about, and this is where your world comes into it, what would a global governance pact look like that would allow much more rapid acceptance and distribution? And I'm sure many of us have been, I preached this at the House of Lords, at the UN. We are no closer to a global governance structure for acceptance and distribution of these kinds of global pandemic issues. And I think that you can see that delays the distribution of vaccines, not only in the developed world, but in low and middle income countries for sure. So if I could appeal to your community, let's figure out a way to generate a global governance structure so that you don't have to wait a half a year to get something approved if it's already approved somewhere else. And that's a very difficult issue.
That is a very difficult issue. So you and I could talk forever, but I'm going to hand it back over to Anthony.
Yeah, I mean, regarding global governance, I saw that the former chair of Gavi was actually recently appointed to head the WTO. So do you see any, I guess, changes incoming for reforming and addressing these health and vaccine access concerns?
Well, I think it's going to. I think it's going to be difficult because this whole notion of sovereignty comes into it, and it's very hard to get one country to say, even between obviously the UK and the United States, we have very similar approval structures. Just because the UK, the medicines program there said it's okay, we haven't, so we still don't even have AstraZeneca here yet. So I think it's going to take committees and groups of people like whoever the 34 participants are in this program to really help us out on that.
Yeah. And I think, it's part of it is that our paradigm is just not consistent with what it ought to be. We are still grappling with, patented technologies for global health needs as a matter of trade, as a matter of commerce, and not as a matter of health. I mean, I think if we change the paradigm, for example, to imagine that we were in a state of war with these diseases, then all of a sudden these boundaries and borders and these inefficient and frankly useless structures that we have talked about for years that have not moved the ball forward would facilitate far better coalition building across borders by governments and policymakers to think about a zone in which we create a transnational governance framework for drug production, drug distribution, drug acceptance, and really begin to think about this differently. Right now, for better or for worse, and my sister's a pharmacist. I love doctors. I love pharmaceuticals. I'm grateful for what they've done, but the idea that this is essentially a firm in a private market with the obligation to improve shareholder welfare is always going to pull away at the best ideas for how to go forward to ensure that the world gets the medicines that it needs and that it gets it on time.
So Chris pointed out there are a couple of questions, and that actually follows right on what Professor Ogbedici was just talking about. So Michael Carlin wants to know if starting a new vaccine technology that could be very cheap to make and stable in a refrigerator on the shelf, are there sources of non-dilutive funding to get such technologies off the ground? Those are that's what I was talking about in terms of research funding. That's very hard to come by because people don't, up until now, it took 5-10 years to get a vaccine approved. So the one nice thing about this whole thing is that it shows the world that you can get stuff done quickly. And the science and technology is beginning to be there to develop these kinds of new vaccines. Thermostable vaccines is lagging behind. We don't yet have enough of these, or any really, thermostable vaccines. And anything that gets developed will still require clinical trials. And so it's still going to take time to develop it. But there is certainly not enough funding to start looking at really novel technologies. And so we really need that, again, on a global scale. This has to be a global effort. And I'll just jump to the next question about genetic differences in populations to account for COVID susceptibility. That's being looked at now intensively by a number of groups around the world. With whole genome sequencing, the ability to access biobanks, to develop biomarkers, and it's very clear the disparities in outcomes is just striking. A lot of data now for general medical access and pre-existing conditions, but the genetic issues will be answered as more research becomes available.
Let me just add to that. One of the challenges, certainly in the African landscape, sickle cell is a huge complicating factor. And in a continent where 2 out of 4 are either carriers or have SS, the effects of the vaccine are not yet known, and this is a huge concern. And so the genetic links become really important as the sort of the vigilance, as we said earlier, post-vaccine receipt. So this is a huge concern on the continent. The second issue related to that, of course, is again how the data gets interpreted, and then ultimately how it shapes policy and outcomes. And this is genetic data is extremely fraught with a lot of historical baggage, and it's unclear how much trust will be sufficient to allow those markers to actually have an impact on the way that this is done. I think one of the things that I've run across is that, and one of the reasons I'm a big advocate for local production, is to begin to address the trust deficit in this space. A lot of bad experiences with experiments on either minorities or people in the global South, Black and Brown people. A huge concern about the lack of knowledge about maternal health and the vaccine. So a lot of questions. And so what happens is, nationally, we may have lots of answers for data in the US, but really there just is not a lot of data, even genetic data, on people in the global South. This is the reality of it. And often what happens is medicines that have been approved, gone for clinical trial in the global North, get passed on. And the consequences of that have really created questions around how we think about the importance of people in the global South and their value and their human dignity.
I see that Mr. Brown just joined us, but before we jump, I want to make a point that it's not only in therapeutics and vaccinations, it's even in diagnostics. There was a fascinating paper that just came out, I think, either in the New England Journal or Lancet, JAMA, I'm not sure where, but we tell a lot of our patients that we're monitoring at home to buy a little pulse ox machine. Put your finger in this little gizmo and it'll tell you what your oxygenation is. Well, guess what? People of color do not register the same level of low oxygen. So even in a very so-called simple diagnostic, when we could be missing very valuable data and to the detriment of our patients. So now I tell my patients, get one, but if you feel poorly, call me, because the people of color will have a different reading on their pulse ox machine. So it's very deeply, it's a very deep problem. I'll shut up now for now.
I think we may be drawing to a close, but I guess we could close with the idea of if Gavi has been equipped to overcome tendencies towards vaccine nationalism. I guess we could start with Anthony Brown. I would love to hear your perspective.
Hi, I'm so happy to be able to join you guys, although it's been quite a bit late. It's been a very interesting day, which I will not get into here. First of all, I have to say that I've been the lead attorney at Gavi working on setting up COVAX, which is a system designed to ensure that the world has equitable access to COVID-19 vaccines once they are produced. Vaccines have started to roll out in countries over the past few weeks. As we see, it has not been easy. One of the issues is that, of course, the idea when it first emerged last February was for all countries to come together in a global solidarity to ensure that vaccines can be dispersed equitably where they're needed the most. That did not happen. We saw right away, maybe it was started by the US with Operation Warp Speed, which had some positive aspects in that it was able to trigger production and a lot of production with manufacturers. But on the negative side, other countries started to say, oh my goodness, the US is gonna just snatch up everything. And then you started already with each country negotiating bilateral doses. And who's left out? You have a lot of smaller countries that are even some middle income, but you had the largest populations in the world in the global south were actually left out. And so COVAX is trying to address this inequity. We've been able to raise funds over last year. The target was $2 billion. That was met before the end of last year. That was start seed money. We have a new target that we set for $4 billion. That was met pretty much kind of quickly, particularly with the $2 billion contribution from the U.S. government. And there's going to be a larger target to make sure that everyone really does have access to a vaccine. Someone said to me in one panel that I did that it would be a shame if a 20-year-old American is vaccinated before an emergency room physician in Bangladesh. And I do think that that's probably right. And we should all think about that and what that means, not only in terms of global solidarity, but what does that mean for bringing a real end to this pandemic and ensuring, as we're seeing right now in Brazil, that there are not outbursts that are so out of control that just new variants are emerging so quickly that we can't even keep ahead of them. I'll stop there. There's so much to say about this, and there's so much to have been said. I'm glad I was able to join you guys.
Maybe can I ask a question? I know there are other questions, but there's been a lot of talk about social impact bonds in terms of raising funds for this event, for the coordinating of this. So Anthony, what's the role, or Ruth, what is the role of social impact bonds, where people can just start, actually, in some sense, contributing to the making up shortfalls?
Yeah, I think social impact bonds can play a role in development in general. Gavi, one of the mechanisms I helped set up when I first joined Gavi in 2006 was the vaccine bond, which was IFM. And it's a way where governments actually can make long-term pledges, but the money can be used immediately by leveraging the capital markets. So the capital markets are an excellent source of funding, especially retail bonds, like a social impact type of vehicle to enable the average person to be able to contribute to a global good.
Yeah, so Anthony, thank you so much we're so glad you were able to join us. One of the things that we talked about before you joined was, even with COVAX, and particularly for countries in sub-Saharan Africa who don't have the technical capacity to even develop or conceive of a national distribution plan, the challenges around these sort of the legal and the social and the cultural infrastructure. And I'm wondering, is Gavi doing anything about that? And relatedly, obviously, one question is, how should government funding of basic research for the COVID vaccine shape the IP landscape? This is a question that many of us have. You know, these vaccines were funded with taxpayer dollars, and the fact that so many of them are now under private property rights that would preclude many in the global South and many in the US and all over the world from getting them just seems paradoxical. And so any insight you could share would be helpful.
Yes, I am not going to touch with a 10-foot pole IP. You had tried to draw me in, but I'm not going to be drawn into that. But I think it's a really interesting topic that deserves a forum in and of itself. How do we come to grips with the fact that manufacturers have been supported, many of them, in the development of this vaccine, if not directly supported through CEPI with research and development. CEPI itself is supported with tax dollars. Then they've been supported with advanced purchase agreements, which means that basically governments purchased a large number of vaccines prior to the vaccine proving itself to be safe and effective, which was basically a risk-free way to continue research and development, if you know you have a certain number of vaccines that are going to be purchased. So all of this money was poured into manufacturers, and you have, in particular, the Global South saying, okay, now share the technology, more than just the technology transfer, but let's open up the technology so that we can mass produce this in different locations. That is a highly important topic. And I hope WTO, with its new executive director, really takes that strongly on, because that is a very difficult topic to deal with. The other one around distribution, Gavi is not directly supporting delivery in a large scale. Delivery can be extremely complex in certain countries because of a number of reasons. If you think about how complex it is here in the US, now you take it to a country that may not have the same infrastructure that the US has. But one of the main elements of delivery, which is so challenging, is that they just don't have the people. It's human capacity, the people who have the training, the nurses to deliver. Now, if you add that with the fact that many people are in remote locations that can't be accessed, and that getting to those locations requires a certain amount of cold chain. This just gives you a sense of the complexity of the issues. Gavi, luckily, certain donors have stepped up and made contributions, particularly for delivery. But we're not there yet. We have a long way to go. Gavi's mission, actually, with the COVAX, is only to support countries with 20%. The World Bank and other multilateral development banks are coming in with loans and other support to get them higher, but that's still not going to do it. We need to get to a place where every country can vaccinate 100% of its population. Otherwise, we're not doing the job done. This isn't a job that you can half do. You have to completely finish the job. I don't know that we want to be stringing this out like we have with polio, and I don't know how many years later, but 50 years later, is trying to get that last child. This doesn't work like that. It's an airborne disease. So wherever it exists in any pocket, it can escape easily.
I'm so glad you talked about that distribution and culture, and that's where we work. And I can tell you that we work in areas where it's actually quite dangerous to be in the delivery infrastructure for various social and political issues. And our groups are in Myanmar and Zimbabwe and places where you need to get to those last folks. I want to add one additional thing in terms of intellectual property. You may recall that even in flu season and getting flu sequences, there are places in the world that said the sequence is our international intellectual property. And why would I share the sequence of a flu virus that you, big pharma, is going to go off and make a vaccine using that data and then charge me money to import the vaccine. So it's the intellectual property doesn't start and stop with the actual product itself. It starts from the basic science. And so we really even haven't solved that problem. And the surveillance that we need for these variants will raise the same set of issues. Who's going to own that surveillance data? Very, very important. We got to solve that problem. And that's why I was saying, and again, why this group is so key. We need a global governance solution to all the problems that both Ruth and Anthony are raising.
Can I just raise one other problem that just needs a solution, because it's the thing that's on my plate now that I've helped to set up COVAX. I've helped to sort of resolve a lot of the liability and indemnity issues, which we haven't gotten into. That's also a presentation in and of itself. But there's one area that we're dealing with now, which is how do we service humanitarian regions? These are populations that are either internally displaced, or they're refugees, or they are in disputed territories. So if you think of areas like Syria, Northeast Syria, or you think of Yemen, which is also having a famine, by the way. You think of Myanmar, which is not in that situation, but it's in the context of I'm not sure what to call it right now, but a social distress. You think of Venezuelans in Colombia. We have to make sure that wherever there are people who are in humanitarian settings, and there are organizations like Save the Children, IFRC, out there doing that, but they also need to be supported. We need to make sure that they have access to the vaccines without crazy indemnity requirements that the manufacturers are requiring countries to sign up to. So this may end up being the last mile. How do we get to the people who are in these extremely complex humanitarian settings?
Thank you so much. I think we have to draw this to a close, but this has been a very fascinating conversation, and you have been such engaging panelists. I'm very grateful for your appearance today. So I think this will be the end of the panel. If there are any closing remarks from Professor Yu.
No, just thank you for a fantastic event. The recording will be available publicly, and I'm sure this will not be the last occasion where all of us have to address this pressing issue, because as you've made very clear, we are far from a solution. And so we look forward to continue to engage in a global conversation on what we learned from this, how we solve this problem, and how we learn what we learn from it for the future.
And let's all pray for Anthony, because he's got it.
Yeah, you got to get some sleep, I'm sure.
Yes, just to say I'm really excited about what we've been able to do, the world has been able to do, but I feel that we can do it so much better.
Well, Chris, I hope that you can use your good offices at Penn to keep this conversation going. I'm sure we've all been on these kind of panels. We talk, we meet great colleagues, and then it sort of stops. But I'd like to turn it back to you and Anthony and say, what do we do next? I mean, you've got two of the most globally recognized people on this panel. We got to do something to solve this problem.
That's a great challenge to set for us. We look forward to trying to put our efforts towards addressing it.
Great.
Thank you very much for joining us.
Dr. Rubin, it was good to meet you. Anthony, it was great to meet you.
Thank you. Very nice to meet you all.
Bye, everybody.